Hello, everybody. Welcome. Welcome to this new installment of our successful public health approaches in dementia caregiving series. We're going to give everybody just a minute more to arrive, and then we're going to start on time, sharp on time. We have a packed agenda, one that we think you will find very interesting, learning about all the work that Vermont is doing. Thank you for being here. All right, let's begin. The first few slides are introduction. So as people arrive, join us, we will welcome them. Maya, please next slide. My name is Elma Johnson. I'm the coordinator of the BOLD Public Health Center of Excellence in Dementia Caregiving, and I'm also the Equity and Community Outreach Coordinator for the Center for Healthy Aging and Innovation at the University of Minnesota. Next slide. Before we begin all of our events, we just want to ground ourselves and with gratitude and humility really acknowledge that the U of M is located on the traditional, ancestral, and contemporary lands of Indigenous people. We take to heart and commit through action to learn and honor the traditional cultural Dakota values: courage, wisdom, respect, and generosity. Thank you. Most of you have probably attended our past events and are somewhat familiar with our center, but just as an overview, the BOLD Public Health Center of Excellence in Dementia Caregiving, our mission is really to support public health agencies in their, and nationwide in developing their dementia caregiving programming and initiatives, and we do that in several ways. The main ones being really by improving access to evidence-based programs as best practices, promoting programs that work, that have been shown to work, in supporting caregivers. We help facilitate connections and collaborations between public health and others working in the space of dementia and supporting caregivers. And finally, we provide technical assistance and support for public health agencies with all questions related to their dementia caregiving initiatives, from selecting programs to partnerships and strategies to implement. Next slide. I will do a brief introduction, and as I do that, please, you all are welcome to use the chat to introduce yourselves, drop in your name and your agency so we know. There will be a brief poll that my colleague Maya will launch in just a minute or two to see who all is in the room, but please use the chat. That's our networking space. We are not in a physical room as much as we would love to see you all in person, but please use the chat, introduce yourself. And throughout the webinar, share resources there. Our center is part of the HBI Collaborative, which is a group of partners, all funded by the CDC under the National Healthy Brain Initiative and the BOLD Act. And our collective goal is really to advance a coordinated public health approach to improving cognitive brain health for all, with a special focus on underserved, underrepresented populations. You can learn more about us, about our collaborative, if you scan this QR code or by visiting our website. Next slide. Many of you know that the new HBI, Healthy Brain Initiative Roadmap, is now available as of a couple of weeks ago. The roadmap is a guiding document for public health response to dementia to improve brain health and reduce risk across the lifespan for all population. This new roadmap has a stronger emphasis on partnerships, equity, and evaluation. Next slide. Oh, I'm sorry, previous slide, Maya. This afternoon, actually, today at 4 p.m. Eastern Time, 3 p.m. Central Time, we invite you to join the webinar where this new roadmap will be officially launched. Thank you. Bringing us back to today's event, this is I believe our fourth or fifth installment of our virtual Roundtable series. Has been very successful, and we are very happy to today feature Vermont it's a bi-monthly series, and in each installment, in each session, we highlight the story of one state. And our goal is really to create a community of learning, networking for public health agencies, where we can share work done and give visibility to everything that the states are doing and share ideas. And finally, this is our community of practice. So please listen for ideas and be ready to ask questions and share your work as well. Next slide. Just a few reminders for the session today. This is a Zoom meeting, so please mute yourself during the session and then turn on your video. Again, we can be physically in the same room with you, but let's make it as close as we can to that experience. Display your name and organization in Zoom so we can know who all is here with us. In your Zoom, please utilize the chat, as I mentioned earlier, as a space to network and to share resources. All of the questions for the speakers, please put them in the Q&A that you also see in your Zoom panel at the bottom. Yes, and at the end, when at the end of our webinar, if you have to leave early, we invite you to please send us respond to a brief survey about today's event. We really value that feedback and take it to heart, take it seriously to inform all of our future events and make them as useful as we can to public health agencies. So the link to that survey is going to pop up automatically when you close Zoom. Next slide. And now Maya is going to launch a brief poll, just as I mentioned, to see who all is in the room. Please take a second to tell us. And Maya, I believe we can share it on the screen with everybody at the end when everyone has responded. We are seeing right now about 40% of community organizations and service providers, followed by 27% of public health agencies here in the audience. You also have some people living with dementia and caregivers as well. Yeah, I think most of our answers are in. Maybe Maya, can we make these results visible? Thank you. And here is who all is in the room with us. Welcome. It's really good to see many of you coming back. We're glad to have you. Thank you, Maya. Next slide. And as we listen to about Vermont's work today, we just wanted to invite you to think about it in terms of the 10 essential public health services. Each state really touches on all of these, but some states are really doing a lot of leading work in a few selected ones. Today, you will really see how building a diverse and skilled workforce really stands out, along with, of course, partnerships and building an infrastructure for public health. So think about this wheel as you hear more about Vermont's team. Next slide. And welcome to our presenters. We have a big group on behalf of the BOLD Public Health Program in Vermont. We have Rhonda Williams and Ed DeMott. And from the University of Vermont, we have Ms. Lori, Jean Hutchins. Next slide. Ms. Allegra Miller, Audrey Vinograd, Lukas Kovacevic, and Janet Nunziata. Welcome to all of you. It will take, they all have a wealth of experience. It will take a long time for me to introduce them all, but you will be seeing them all on the screen. They will be highlighted as they speak, and you will be learning more about their work. And we invite you to connect with them after the webinar to learn more. Next slide. And without further ado, because we really have a full agenda, I'm going to hand it off to Ed at this point with the Vermont BOLD team. Thank you, Ed.
Great, thank you, Alma. A little bit of self-disclosure. I'm grappling with a pretty mild case of COVID, so if I sound a little froggy, I apologize. I'll try to project. So my portion of the presentation is just to review initially a little bit about the infrastructure for the Alzheimer's Disease and Healthy Aging Program in Vermont, a little bit about our action plan, and some of our training initiatives that we have in place and some that we're projecting to do in the future. So thank you all for being here. Next slide, please. So just for some background, in 2020, Vermont entered into a cooperative agreement with the CDC for a bold public health program to address Alzheimer's disease and related dementias, a core capacity level grant. At that time, the department was in a tier 1 response to the COVID pandemic. But later in that year, of year 1, the Alzheimer's disease and healthy aging program was fully staffed with Rhonda as PI, myself as program manager, and our public health analyst, Julie Scarha. And just to give you a little context about Vermont, because it may become apparent later on when we refer to different agencies, Vermont is a centralized public health system with 12 offices of local health that basically carry out the work of public health in our individual communities. So just so that's clear. Next slide, please. So the work of the program is based on the 4 domains of the HBI roadmap, which of course was built on the essential public health services. And so our program basically applies coordinated, collaborative, health equity informed approaches in dealing with aging, memory, clinical and social services, and when working with our chronic disease partners. The work of the program is achieved through a robust coalition, strategic collaborations with colleagues in chronic disease, substance use, injury prevention, and with the Vermont Department of Disabilities, Aging, and Independent Living, which we'll refer to as we go forward as DALE. And you may hear that acronym throughout the presentation. Next slide, please. So our program, in partnership with DALE and numerous other organizations, has built this strong ADRD coalition, which is basically composed of 4 work groups. And let's just take a minute to explore the nature and intent of each of those work groups. There's an Alzheimer's disease and healthy aging work group, which focuses on infrastructure building to address ADRD. Secondly, we have the Governor's Commission on ADRD, which advances a multi-sectoral approach to workforce, training, and other domains, including policy. We have our Hub and Spoke ADRD work group, which works principally on building the capacity of the clinical community to screen, diagnose, and care for ADRD for folks with dementia and for their caregivers. We'll look at some examples of the Hub and Spoke work in a few minutes as we go forward. And lastly, we've got a chronic disease program partnership to integrate brain health, which is essentially to raise public awareness and educate providers about the relationship between brain health and chronic disease prevention and management. Most of those folks are co-located with us in the Health Promotion and Disease Prevention Division of the Vermont Department of Health. Next slide, please. So Vermont had an initial action plan for Alzheimer's disease, which was released in 2018. And the plan helped move public health and public health partners toward a more comprehensive approach to addressing ADRD. And the plan that we're working with now was released in the fall of 2022, builds upon this more basic plan. And the current plan is more notably broader and deeper focus. But the action plan from 2018 served us well, and again, provides the basis for our current plan. Next slide. For our new plan, the cover of which you can see on the right there, we had an extensive stakeholder engagement process, and we sought input for a range of partners, traditional public health partners and some more novel, non-traditional partners. All in all, we had representatives from 39 statewide organizations. And to ensure that we honored the ideal of nothing about us without us, we reached out to individuals with lived experience, folks with a dementia diagnosis and family caregivers as well. And so we're happy that their input is included in the development of this plan and indeed in the final product as well. The current plan includes 19 HBI roadmap actions, and especially those addressing social determinants of health, and of course, always with a mindset toward health equity. Next slide, please. These are the major action plan goals that we garnered essentially from the National Alzheimer's Plan. And the highlighted portions, you'll see those that relate to caregivers. And so there's significant attention paid to caregiver acknowledgement, caregiver support, and caregiver health. Due in part, no small feat to get the input of the very engaged caregivers that we had involved in our stakeholder engagement. Next slide, please. So I mentioned the hub and spoke work group as being one of the core groups for our coalition. And so just wanted to talk a little bit about that group. It's been in place for several years, probably around 7 by now, way before I was program manager. While the primary focus of the group is to move primary care toward a greater dementia capability for screening, diagnosis, and management, we also have a caregiver component that we focus on. You'll be hearing from Allegra a little bit later in the program. Allegra is one of our very engaged caregivers and a member of our Hub and Spoke team. The Hub and Spoke work group developed and promoted a project ECHO for dementia diagnosis, care, and management, which included modules covering caregiving, guardianship, and community supports for caregivers, in addition to the modules for dementia diagnosis and management. So it's a very comprehensive program. Vermont Health Learn consists of courses created through a partnership between One Care Vermont, the Department of Health Access, the Blueprint for Health, and the Vermont Department of Health. These courses are available to any medical professional in their own time, also covering the same topics as Project ECHO. In fact, some of Project ECHO is just adapted to become modules of Vermont Health Learn. We link caregivers to the T-Care assessment conducted by our AAAs to determine appropriate supports, reduce stress, and build skills. And our dementia-friendly communities promotion is being launched. And the program will meet quarterly with our offices of local health and semi-annually with our Agency of Human Services leadership to move Vermont communities to dementia-friendly status, which of course benefits those with a diagnosis of dementia and their caregivers and families. Hub and Spoke will build on current work to expand community clinical linkages in several areas, including the promotion of adult day programs as an integral component to caregiver respite. And we're also working with our accountable care organization to designate adult days as medical homes. So more to come on that initiative. Next slide, please. So the work group, the Hub and Spoke work group, also facilitated extensive conversations between the University of Vermont Medical Center and its memory program, the UVM College of Nursing and Health Sciences, and the UCLA Alzheimer's and Dementia Care Program to begin conversation about adopting the UCLA dementia care model. That is actually happening. We're proud to say the pilot, the Vermont Alzheimer's Disease and Dementia Care project will be launched in the fall and will increase care through a dementia care specialist, a dementia care assistant trained through UCLA, and the initiative will be overseen by Dr. Mary Val Palumbo, a geriatric nurse practitioner, and Dr. John Steele, a neurologist from the University of Vermont Medical Center Memory Program. The team will follow patient and data management protocols beginning at the memory program and in rural clinics in northwestern Vermont. And if it's successful, which we're sure it will be, we'll create a sustainable care model that could be replicated in other health service areas. Vermont being the second most rural state in the country, often faces challenges with access to services, and accessing healthcare, of course, can be difficult. So distance, responsiveness, that access to care component have all been touted by caregivers as sources of concern. And we think that the pilot will cultivate a broader reach for responsive dementia care management. Next slide, please. Other things that we're working on are dementia certification for community health workers, promoting Alzheimer's Association trainings for first responders, engaging our Department of Mental Health's Director of Trauma Prevention and Resilience Development, who offers trainings on trauma-informed care for healthcare professionals. We're also looking into our Medical Reserve Corps as a potential partner to deliver education and raise public awareness on ADRD. And of course, we're partnering with our offices of local health to roll out dementia-friendly communities throughout Vermont. Next slide, please. Vermont is Alma mentioned the new HBI roadmap. Vermont is honored to be featured in this new edition of the roadmap. The featured work basically looks at the work that we did with the Vermont chapter of the Alzheimer's Association to curate a series of virtual workshops for human services personnel. The series was promoted throughout the Vermont Agency of Human Services, over 1,000 employees, which includes the health department, Dale, and other departments offering services and supports to Vermonters. In addition to providing insight into the signs of ADRD and how to recognize and be sensitive to these when dealing with individuals that appear before them with a diagnosis or their caregivers, the program also supported employees in Vermont's agency that are caring for someone with Alzheimer's disease or another dementia, or who are at risk themselves. So that'll be my component of the presentation. I thank you very much for your attention. And at this point, I'll hand off to Rhonda to cover a bit about the state system that helps support ADRD caregivers. Rhonda?
Thank you so much, Ed. And I'm very honored to be here as well. I'm the director of the Alzheimer's Disease and Healthy Aging Program for the state of Vermont. And I'm also the PI for several other chronic disease programs. So in my position as the lead for healthy aging for the health department, I just want to talk about a few pieces that relate to those public health services and how we seek to support and augment the work you're going to hear about from other partners on this call. In part, I wanted to speak a little bit more about our work with our sister agency that leads the disabilities aging services. So as Ed mentioned, that's the Department of Disabilities, Aging, and Independent Living. And for the next slide, thanks for advancing, it shows at a glance some of our infrastructure. And on this slide, our BOLD program works closely with our Division of Surveillance. And why that's important is public health can collect not only our surveillance data, but use other program and intervention data. And we seek to support our aging service partners, including those here on the call, to understand how well are we doing around supporting and improving the quality of life and health of dementia caregivers. We work closely and increasingly specifically with our 12 offices of local health. With Dale in the green circle there, we share two positions, one for a surveillance position to over time build out Alzheimer's related dementias and healthy aging data, and to show over a lifespan approach both the risks and also the protective factors for aging well in Vermont, including, importantly, caregivers. For the other position we share with Dale is around aging and substance use, in particular alcohol and medication mismanagement. And lastly is that we work collectively on our state plans. How well can our state plans on aging, our action plan on Alzheimer's and related dementias, healthy aging, our state health improvement plan, how can those support caregivers over time? So next slide, please. Starting with Act 156, the legislature set forth a vision for Vermont's first master plan on aging. So this is a joint effort between our sister department, Dale, and the Department of Health. And through this, we're able to integrate strategies from our BOLD program, from our action plan on Alzheimer's and healthy aging, from the Healthy Brain Initiative at the national level, and from our state health improvement plan. Now, our SHIP, our State Health Improvement Plan, is an equity-based model, race forward, and over time will help us to achieve greater equity, including for caregivers. Our new master plan on aging, which has been recently branded Age Strong Vermont, supports our older Vermonters Act principles, in particular, a comprehensive and coordinated system of care, and supports and protections for older Vermonters. This is what advocates and caregivers' testimony have been telling us for a while in our state legislature. They want to see improvement in a coordinated and communicated system of care. So we're focusing in our master plan is to take the Vermonters Older Act principles and make them more visible and with specific strategies and actions around optimal wellness, financial security, autonomy, safety, that will bring forth those protections and benefits to our dementia caregivers as well. Next slide, please. So part of our role in our bold public health approach is to support, communicate, help bring data to understand the services and supports that are offered through the state of Vermont. So in acknowledgement of what this set of services is and how can we augment that in particular for dementia caregivers. Sadly, our red circle didn't land quite where we had hoped for, but hopefully it'll still come through in terms of what we're aiming to do. So funded primarily by the Administration of Community Living, our 1115 waiver as a state, and then the state legislature funneling to our sister agency, Dale. Hundreds of service providers are implementing these services to 55,000 Vermonters. And these services include, but are not limited to delivered meals and as well as homemaker services and respite care. The challenge is dementia care partners in particular have expressed frustration around where can they go for services? How can they tap into them more easily than what is currently available? One of the challenges is that in our state, services through our area agencies on aging are often named differently. And people don't necessarily know, does that service, is that available in my community? So a lot of frustration has been expressed and we've heard that. Fortunately, our state legislature responded this year and has put in forth $150,000 a year for a dementia coordinator, a new position to address these issues and to help build a better and more communicated system of services. And for us as public health to help track that. So the dementia coordinator will sit in our sister agency, Dale, but we will, as a bold program and in partnership, our 4 work groups and coalition will work closely with this position. Next slide, please. So Vermont's workforce strategy includes 3 priorities to support family caregivers. One is to improve the training and the payment level for our home and community-based service workforce. There has been a lot of testimony on the need for this workforce among other workforces, and this resulted in a significant pay rate increase for this workforce. So we're excited to see that. We're also assessing trainings that meet feasibility and capability for this and other workforces on building more dementia capacity. Also, another strategy is to build partnership and leverage the resources of partnership. as Elma mentioned early on, is one of the foundational pieces of public health service. And when looking back over the last 4 years, we have grown that. It's encouraging to see. So we were able to gain the CDC funding for being a BOLD recipient, core capacity. We've been able to receive state legislative funding for the first time for this area of our work in public health, and shared with Dale and others. And we have 2 foundations in Vermont that are giving towards the dementia care model. That's a private foundation at the medical center, as well as for increasing evaluation for our master plan on aging, Age Strong Vermont. We need evaluation services to be able to assess how are we improving that coordination of services, including for dementia caregivers. That's the Vermont Community Foundation, which historically has had a real emphasis on youth and youth issues. And over the last year, through meeting with partners, they've become interested and I think committed to aging issues in our state. So we're leaning into that. And then partnerships, growing those partnerships. So some recent ones include what Ed mentioned around the UCL Dementia Care Model Team. Also the NYU BOLD Center on Early Detection and Diagnosis, so important, right? We hear from Vermonters and certainly nationally from caregivers around how difficult it is to wait 1 or 2 years to finally get a diagnosis. Without a diagnosis, getting some of these supports that you're going to hear about today are that much harder. So we really are honing in on early diagnosis and detection, as well as dementia caregiving expertise through the BOLD Center on Dementia Caregiving that is hosting this webinar. And our third priority area is seeking innovation. And so innovation can take so many different forms. And I just wanted to mention that I think we're seeing innovation in peer monitoring, peer mentoring, working with an aging population in our state correction system, as well as providing more accessible disease management and disease prevention interventions, which I'll tell you a little bit more about in a couple slides. So next slide, please. So this is just a snapshot of specific service components offered through our state system to support our care partners. Certainly, if anybody wants to hear more about how Vermont delivers these or what our more specifics are, we're happy to put you into contact with the program leads. But I will mention that Vermont's respite and training components include self-directed care and case management that's tailored to both the care recipient and the caregiver as part of our philosophy for supporting care, our care partners, dementia caregivers. Next slide, please. So as you heard already, several of the evidence-based programs you're going to hear more about are listed on this slide. And in particular, the T-Care model is one that the BOLD program has become interested in. How can we better understand its delivery? Are there any challenges to that delivery that we can help convene meetings, share data to maybe address and make it a more successful intervention? So one strategy we use from public health and our BOLD program is looking at how we can promote that's low or no cost. We have a monthly newsletter, Alzheimer's and Healthy Aging, that has I think our listserv is more than 350 now. We also look to what can we do through digital promotion, and we're starting in the fall, simple newsletter, helping to bridge to, raising awareness, but using print. because not everyone, right, is online. And certainly in a rural state and an aging population, we should not expect that that's the only way we reach people. So we're really trying to stretch ourselves and deliver in more methods our communications. So we'll be working with our congregate meal settings and partners to do some of that delivery. Next slide, please. So we have a question for you, and you're welcome to put into the chat. What challenges have you faced in building supports and services that benefit dementia family caregivers? You know, this is relevant whether you're in a clinic, social service organization, a state public health agency, or BOLD program. We certainly look forward to, and come on, you know, you can unmute yourself too and speak. Does anybody want to share? And no pressure, you don't have to do it right now, but we are interested in challenges and how you face those challenges on this important topic.
And these can be links in the chat. If you come up with the answer to the question, feel free to drop a link in the chat to your website or any program that you've implemented or any report on your work.
And I see Patty stating, you know, building capacity. And I will say we have faced some of the same, right? Because the capacity building takes momentum. And it's just like, right, how do you find time to make sure you're keeping the threads and those relationships nurtured sufficiently for capacity to be built?
I also see here challenges getting caregivers to come to support groups regularly. I mean, among many challenges, I'm thinking particularly in Vermont, and mentioning the second most rural state, and how transportation and finding the respite needed for that time is made available and accessible comes to mind right away. By the way, Rhonda, we have about 3 minutes left for your section of but there are quite a few answers here.
Yeah, that's great. And I agree with not enough options for respite, especially in Vermont. We're seeing our volunteer base reduce in this arena too. So next slide, please. Just a quick mention is that we are working on, Ed and our analyst BOLD team, on a new lived experience data brief on caregiving, taking interviews with dementia caregivers and matching or pairing with our 2021 BRFIS caregiving data from the caregiver module. So that will be available on our Vermont Department of Health Alzheimer's and Healthy Aging Program website soon. All right, next slide, please. And that in My Healthy VT, this is our, so it's paid through dollars from our state Medicaid program, but administered by the Department of Health. And our BOLD program has increasingly become involved, as Ed mentioned, like integration of brain health into chronic disease prevention and management. So My Healthy VT, what we are aiming to do is to bring Tai Chi for arthritis and falls prevention to be more accessible through My Healthy VT. It's easy to enroll. It's easy for us to promote. And importantly, it's integrated with other programming that may be of interest to caregivers who are often, right, restricted in their time and their ability to leave and go to outside community-based programming. So we're doing both online and getting, we hope, intend to in more remote areas of the state with in-person through this program. It's part of our dementia risk reduction efforts, including caregivers. Next slide, please. And we just wanted to mention that our brain health and dementia web pages, they focus in on dementia family caregivers. So feel free to look at this, give us feedback if we're missing things, or if you find something of interest, please reach out to us. Next slide, please. And just as I mentioned, My Healthy VT is for caregivers too, which is really important. And they are free local support. And we're looking at the data as well for results. Next slide, please. And dementia friendly. So, you know, in Vermont, we're not quite there, but we are releasing a new website or webpage next month to get dementia friendly Vermont. We've been very interested in dementia friendly America. And as a caregiver, my mom had mixed dementia who passed earlier this year. Like, what a difference it can make when we have environments that are more suited and managed for those with dementia. So we are working with Office of Local Health and partners on building awareness and visibility and the value of dementia friendly for and inclusive of care partners. And next slide, please. And my last minute is our new data pages, Alzheimer's and related dementias. We will be putting on more caregiver data in here. You know, so basically cross-tabbing with chronic disease, risk behaviors, dementia risk, and the ways to reduce dementia risk, importantly for our caregivers and care partners. So we have one last question for the audience. What are some of the most compelling caregiving data points that you are using in your clinic, jurisdiction, public health, community service organization? Thank you for sharing in advance through chat. And I am going to thank you for being on this webinar today. And am going to now hand over to Lori McKenna, who is the Assistant Manager at the University of Vermont Medical Center Dementia Family Caregiver Center. Thank you.
Thank you, Rhonda. And as folks answer about the data points for caregiving, just a question for you. When will the data portal, the data pages be live or be launched?
They are already available on our website.
Okay.
Yes, but we are working on adding other data elements that are not yet put together all in one setting. So more to come, but you can find them and we'll put it in the chat as well.
Thank you. Thanks. We're going to hand it off here, pass it off to Ms. Lori McKenna, but those of you in the audience who would like to share more about the data you use related to caregiving, please share it in the chat. Welcome, Lori.
Thank you. Very happy to be here today and present our work as we move from policy to programming. We'd like to tell you about the Dementia Family Caregiver Center that we have been fortunate to begin working on the past year and a half. Next slide, please. So actually, the Dementia Family Caregiver Center, the ideas have been born over time, have evolved. And if we look back in time, probably at least 7 years ago, we started thinking about how could we better serve caregivers in the state, and highlighting some of the things that Rhonda just spoke about, given the rural nature of our state, and also listening to hundreds of family caregivers' stories when they relayed to us that coordinated care or being able to afford care or having respite, all of the things that many of you mentioned in the chat as things that you're witnessing really make it very, very difficult for family caregivers to provide care at home. Specifically, we're interested in decreasing ED visits and delaying residential care by providing care for persons with dementia in their own homes. Next slide, please. So the primary mission of the Dementia Family Caregiver Center is to support family caregivers of persons with dementia to remain in their own homes. And I think this photo beautifully illustrates that mission. A grandmother reading to her grandson. Next slide, please. So the Dementia Family Caregiver Center began with 4 primary initiatives. And we will be speaking about those more at length today. The first one is to create a dementia care pathway where families can call and ask for resources, referrals, identifying different community partners. We are not reinventing any of the work that's already being done in the community, but simply becoming a gateway to let people know where these services are and do warm handoffs to them. Next slide, please. The second thing that we is one of our initiatives is the development of therapeutic caregiver groups. These are evidence-based groups, and they are established by the Reitman Center, Mount Sinai, Toronto, and based on their research and shown to impact caregiver burden positively and to increase problem-solving skills. And lastly, we have also become master trainers so that we can advance these programs throughout the state. Next slide, please. Our third program has become or is a peer-to-peer mentoring program. Our pilot began in April of this year, and it is a volunteer model of care that matches someone with experience as a caregiver to someone who is new with caregiving. And we'll hear more about that in just a moment. Next slide. And lastly, one of our initiatives, the fourth initiative, is the Workforce Development Project. And we're very proud to be mentioning the Vermont Bridges program, which is designed to educate and recruit, first of all, educate and retain MSW candidates and then MSW graduates in the field of aging and hoping for them to be retained in Vermont. Next slide, please. Program goals of the Dementia Family Caregiver Center, as I said, are to decrease ED visits, delay residential placements. We are serving currently 100 family caregivers in a year. That will certainly increase as we have more faculty. We will continue to serve as a gateway for existing services for family caregivers and primary care offices. It is our hope that we can be consultants to other people in the state to expand the volunteer peer-to-peer program, and workforce development is slated to begin in August of this year. Next slide, please. So I'm going to hand this off to my colleagues, Jeannie Hutchins and Allegra Miller, who will be talking with you about the peer-to-peer mentoring pilot.
Good morning. I'm Jeannie Hutchins. I'm the Executive Director for the Center on Aging at the University of Vermont College of Medicine, and I am the manager of the Dementia Family Caregiver Center. Next slide, please. So I'm going to talk about challenges caregivers of people with dementia have and how the peer-to-peer mentor pilot kind of came to be. So we have all seen the numbers. There's an aging population, which leads to an increase in people with dementia, which leads to an increase of the amount of caregivers. So these are the numbers for Vermont. We know that the caregiver is not only essential to the person they are caring for, but they're also an essential member of the healthcare team. Caregivers are essential and they need lots of different kinds of support. Next slide, please. So what are some of the needs of the Family Caregiver Center, or the family caregiver? So they're grieving the loss of the family member as they watch them slip away. So there's grief. There's a lot of stress, so many decisions every day. And every day may bring different challenges for the caregiver. They might have or develop their own health issues, often socially isolated because they cannot leave their family member at home alone, and emotional turmoil. So we hear from caregivers, I never thought I would be responsible for everything. Some caregivers still have children at home, and some are also caring for multiple family members. Next slide, please. So how can we best support the family caregiver? This list reflects what we know about family caregivers. So we thought, is there an inexpensive way to support individual caregivers without crossing the lines of therapy? Could we do it with volunteers? Next slide, please. So we were influenced by the CARES therapy groups, which Lori will talk about in more detail in a moment. In Vermont, there's a wait list for assessment of dementia and counseling for caregivers. And I see in the chat that a lot of you are experiencing the same thing. Caregivers we talked to just wanted someone to talk to who had been down the caregiver road while either they waited for assessment or they waited for counseling. We recognize that not everyone could attend a caregiver support group or want to. And there's never money for a new program. So then we were approached by our next speaker, Allegra Miller, who was a caregiver and very much wanted to start a volunteer peer-to-peer mentoring program. Allegra? Next slide.
Please. Thank you, Jean, and good morning, everyone. And thank you all for being here and for including me. This is truly an honor for me. I am sure many of you have benefited from a mentor at some time in your career. As an educator, I have been significantly impacted by structured mentor programs, either as a mentor and sometimes as a mentee. I have seen and felt the incredible power of a mentor, someone who has been where you have been and can relate to the emotions, decisions, circumstances, and the overall anxiety as you progress through within your new responsibility. As a caregiver for my husband, who traveled through the entangled path of Parkinson's with Lewy body dementia, I realized that the role of a family caregiver is like no other. Sometimes discouraging, demanding, shattering, and then at other times joyful, hopeful, meaningful, and of course, loving. It is with this background and mindset that Lori McKenna, Jean Hutchins, and I began working together to create a peer-to-peer mentoring program for the family caregiver. And as Jean mentioned, it is all volunteer. And as we began to create this framework, we knew we had to articulate what the mentor would offer. For this program, we focused on these 5 categories you see in front of you. The overarching thread that connects these categories is the personal experience of the mentor, providing an opportunity for the new caregiver to share and have conversations with another more experienced caregiver within this structured framework, we believe is a critical component that will continue to support the family caregiver. Next slide, please. This idea was further validated by Dr. Jory Fleischer as we researched other possible peer-to-peer mentor programs for caregivers of people with dementia. We found Dr. Fleischer. After several email and phone call exchanges and explaining what we had hoped to do in Vermont, Dr. Fleischer generously shared her current expertise and knowledge with her Persevere peer mentoring program. This information and her ongoing support and encouragement have been really critical in the formation of our program. Her contact information is listed here if you want to learn more about her program and randomized clinical trial. She welcomes the opportunity for more conversation with you. Change slide, please. Along with the specific criteria that you see listed here, interviews were conducted before matches were made to ensure the matches of mentee to mentor would be supportive and share similar experiences. Our pilot program right now, we're in the middle of it, has 6 mentors and 6 mentees. It's very exciting. And I am fortunate to be a mentor, as I have found this personally rewarding and supportive to my mentee as she travels this path with her husband. We are able to meet weekly in person and connect by phone or text when needed. Additionally, for me, the monthly meeting with a support coach has been beneficial as it keeps me grounded, provides ideas for other discussions, and offers support with topics that, quite frankly, may be triggering for me. Another aspect that I have found really helpful to me is that as a caregiver, you go through so much, and to be able to talk about this with someone else who's starting to experience the caregiving, family caregiving of someone with dementia, it's very validating to to remember and to be able to share your experiences in a helpful manner. Change slide, please. In front of you is a list of topics we discussed in our mentor training. Although all of these are essential, the two topics that have been supportive in my mentoring so far are the progression of dementia and the different types of grief and loss. It has been especially helpful to have concrete words from the training to blend in with my personal experiences. Additionally, in our training, we were very clear what a mentor does not do, such as give therapy, offer medical advice, or provide respite. Next slide, please. So this in front of you is what we have learned so far. We are still continuing to monitor the progress that everyone is making and trying to get as much as we can through surveys, our individual coaching sessions, and just other anecdotal information. We still have more to do. We will do a final survey and meet with our mentors at the end to continue our learning as we plan for our next cohort. Personally, I have found that the phrase bearing witness is enough has been significant. As a caregiver, we want to solve all the problems. As a mentor, that is not our role. We listen, validate, share experiences, and become part of the community of support for the family caregiver, hopefully helping them find their own resilience, recognize moments of joy, and find solace through the knowledge that they are not alone on this path. Lori McKenna will now speak with you about the CARES and TEACH programs. Thank you.
Thank you, Allegra. Next slide, please. So before I begin talking about the CARES program, I certainly want to give credit to where these were developed. I mentioned just a moment ago, they were developed by the clinical research team at the Reitman Center in Toronto, specifically highlighting Dr. Joel Sadavoy, Dr. Virginia Wesson, and Gita Laktapal. And if you want more information about these programs and how to bring them to your community, please contact either Jeannie or myself after today's presentation. Next slide, please. So what are therapeutic groups? They're innovative. They are an intervention that provides education. They provide support. They provide skill building. And these groups are unique to family caregivers of dementia. We have two models or two programs. One is the TEACH group, which is specifically for family caregivers who are relatively new to caregiving for someone with dementia. And then we have the CARES program, which is really meant for people who are providing care to someone with either mid-stage to advanced Alzheimer's disease or related dementias. Next paragraph, next page. Our goals are to expand these groups across the state. And unbeknownst to us, one of the benefits of the pandemic was that in early 2020, when our state was shut down, we had to very quickly pivot to not only learning how to provide groups virtually, but how to market and how to reach out to all corners of our very rural state. And it really has been a gift that we had not anticipated. At this point, all of the groups that we are offering are offered virtually, but do not have to be. Some people have interest in returning to in-person groups, and that's fine as well. The groups that are offered are specific to either spouse caregivers or adult children. There are two separate groups for each. Next slide, please. So the clinical goals of the CARES group, the CARES program, is to recognize that caregivers are a vulnerable group that are at high risk for both psychological and physical problems closely associated to the burden and stress of caregiving. The program is based on therapeutic relationships, so relationship between the facilitator and the group members, relationship between the facilitator, and individuals in the group, and relationships between group members. The program addresses the complexity of dementia care, specifically with an educational model and formal problem-solving techniques that are derived from cognitive behavioral therapy. The program accommodates the needs of adult learners, specifically by recognizing that adult learners are self-directed, that people come into this group with years of experience and knowledge, that they are goal-oriented, and that adult learners want practical material that they can begin to apply. The program is primarily experiential and offers these skills listed on this slide. Next slide, please. So what is TEACH? TEACH is an acronym for training, education, and assistance for caregiving at home. It also is a therapeutic group. It is 4 weeks as opposed to the 8-week carers program. It is targeted toward family caregivers who are new to dementia caregiving and really learning about existing resources in the community. Each week has a theme. Each of the 4 weeks has a theme, such as personal care, addressing resource development, future care planning, and most importantly, or certainly of most importance, is the caregiver's self-care. Each caregiver will leave each week with an action plan of something that they're going to work on over the next week to further their knowledge. Next slide, please. So the rationale for using problem-solving therapy, why do we do that? Well, if we look at some of the feelings that we hear from family caregivers who are experiencing perhaps stress in their role, they may offer things to us like feeling fearful, being overwhelmed, grieving, sometimes exhausted, particularly if their care recipient is not sleeping well. Sometimes people are angry. Sometimes people are grieving their loss of identity. And sometimes we are hearing about such things as depression and anxiety. The practical issues often are resulting from not having respite, perhaps not having a good understanding of dementia, and perhaps projecting things that are happening on themselves. Could be financial challenges, it could be relationship challenges, all of these things to just highlight some of the things that I know that you have all seen and heard. But when people are experiencing that, it creates a cloud, if you will, which impairs problem-solving capacity. So the Carers program utilizes a step-by-step technique where we help caregivers identify a very tiny component of the problem that they can solve. And I will give you an example in our next slide. Well, the slide after this one. The 8 steps of problem-solving therapy, just to quickly run through this, we develop a problem list. This is done with the group as a whole during the beginning check-in process. We work then with an individual who has agreed to go through this process one by one and help them to clarify exactly what the problem is into a very specific SMART goal. We then come back to the group, and the group as a whole brainstorms solutions without evaluation. Come back to the individual in step 5 to discuss the efficacy of each and every offered solution by saying, is that a pro? Is that a con? Is that maybe something that you would like to try? The caregiver then chooses a solution, and we help them to develop a very specific action plan that they will begin over the next week. And then in the following session, they come back and we look at how the action plan went. We review what worked and what didn't work and offer new solution if something needs to be tweaked a bit. So those are the steps of problem-solving therapy. Next slide. So an example of problem-solving therapy, one caregiver's story. So an older gentleman who had been a family caregiver, was a family caregiver for his spouse of many, many years, who required 24/7 care, came to group one day and expressed the enormous amount of new grief that he was experiencing. He himself had had a health emergency over the previous week and had to go to the emergency department for his own care. He did not have care for his wife and chose to leave her to attend to his own health. And this had a profound effect on him because he felt he was leaving her at risk. So he participated in problem-solving therapy, and through the help of the group, he was able to come up with an action plan where he would ask his son, his adult son, if he would be the primary person on the emergency call list that he was creating. So he was all good to go with that. He came back the following week and had done what he said he was going to do. But not only had he done that, he had 7 other people on his list for emergency contacts. He had talked with neighbors, he had talked with grandchildren, and he had talked with people that he was associated with in a civic organization. So he had a robust list of people that were going to help him, and his stress level was greatly relieved. Secondly, when we think about the impact that this had on group members, as other group members heard his story and saw the work that he had done, they said there were 3 people in the group that said didn't have emergency contacts either. So they too began to create this list. So that just shows the power of the group and also the power of problem-solving therapy, where this person had agreed to do one thing, came back with a robust list of 7. It was phenomenal. Next slide, please. So the structure of the CARES program, and I didn't mention that CARES stands for Coaching, Advocacy, Respite, Education, Relationship, and Simulation, occurs over 8 weeks. I did say that these groups are separated into spouse partner groups and adult children groups. And certainly we do have people who are other family members, such as siblings, who may be providing care, and we will fit them in to the group that makes the most sense for them and for the group. The 4 major elements that are covered in the CARES program are certainly dementia education, the utilization of PST, which I just reviewed. We also use simulation, which I'm going to talk about in a moment. And simulation is a simulated patient that participates first as an observer in the CARES group and then later as an integral person with role play. The program also offers once a month follow-up for a year if people want to do that. So between the 8 weeks of the weekly group sessions followed by possible up to 1 year of monthly follow-up, it's a considerable amount of support to a family caregiver. Next
Lori,
slide.
excuse me to interrupt. We have about 4 or 5 minutes left.
Great.
Before we start the Q&A.
Oh, okay, then I will really go quickly. So simulation is, as I said, is role playing and coaching. Next slide, please. Next, we're going to talk about Vermont broadening resources and developing gerontological education and social work. So I will quickly hand this off to Audrey and Lucas.
Hi there, I'm Audrey, but I don't see that spotlighted here. So if you could bring me in, I'll start talking. Can you hear me, Lucas? Okay, all right, so you don't need to see my picture. I'm Audrey Winograd, and I am, there we go. Okay, hopefully we can get Lucas on there as well. There we are. Thank you. Okay, I am the coordinator of Vermont Bridges, and as you can see, it's also an acronym for a program that we have developed to increase the number of social workers working in aging. And so in the interest of time, because we only have a few minutes, I'm going to try to integrate a couple of the questions or comments that I've seen in the chat with what we have on our very few slides, and we'll run through it. Most importantly, it's a pilot project. And so what I'd like you to know is that we want all of your input, all 100 and so of you and those that may be watching this delayed. We want your input, and we want to be able to report to you what we have found as we develop and run this program. So the University of Vermont Medical Center's Dementia Family Caregiver Center, the University of Vermont Center on Aging, and we've had great support from the University of Vermont Social Work Department. And Jean, who is on the call today, is the field education coordinator and lecturer there. And we also have some of our new interns. So this is a workforce development project. So when you think about those, that initial slide where you have the public health services and the domains of policy development, assessment, and assurance, this falls into skilled workforce. And also we're focusing on social workers. And there are so many people in this room today that come from social work, but also from people with dementia, caregivers, clinical staff, and we need everyone to help out. Some of the comments that I've seen in the chat, and I'm sorry if I get your name incorrect, from Megan Reed from Dartmouth Hitchcock says we need more workers. Yes, that's what we're here to talk about. One thing that we're not going to talk about today with a short amount of time is how do you get the money, not only to provide a program like this where we're providing stipends and we're developing this, but also to fund new positions. So Megan, I appreciate that. And Tani says that the AAA staff are already at capacity. Well, workforce of development is about that, and it's about addressing that. Also, reach out to us if you want to talk about how do you fund this. And Eugene from Boston Public Health talks about the lack of linkages between the community and the clinical. And that is one of the focus that we're going to have during our year. So next slide, please. So the mission, again, is to enhance workforce development within the field of social work with our elders. And as Vermont's population ages, there's a need for a greater number of trained social workers. That's how we came to this. There's also a need for many other clinicians. This is a pilot project. It may include your group of clinicians in the future. I don't have time right now to tell you about the method that we use to research and develop Vermont Bridges. Again, reach out to us. I will say that we interviewed social workers at all levels, new social workers in the field, mid-career and senior level career. We also met quite a bit with the social work department. Again, I just have a great admiration and appreciation for their involvement with us. And we also looked at a lot of models around the country to see if there weren't any. There weren't many at all. So we hope to share that in the future. Next slide. Okay, so just a closer look at Vermont Bridges. It's going to involve specialized coursework. So we have a group of interns that are MSW students, and we're going to integrate specialized coursework. It's a little bit of a challenge given the size of the program and the fact that the program at the University of Vermont is both clinical and macro, both community and clinically trained. We are very blessed to have the return of Kelly Malekas, who is a social worker who specializes, a professor who specializes in gerontology. So she's working with us on that. So that's really important. Lucas is going to mention a little bit about the rotational site placements and his experience with that.
Hey everyone, my name is Lucas Kovakovic. I'm the Vermont Bridges Program Administrator and a recent graduate of the University of Vermont's MSW program. So my direct experience within the program kind of speaks to some of the work we've put into the Vermont Bridges internship program. So our rotational site placements are one of the 4 unique elements of this internship program. Much akin to a medical model, we're hoping to we're planning to place students in more than one site placement throughout the year so they can get a breadth of experience, context, and modalities. So this last year, I was placed within neurology in the University of Vermont Medical Center, as well as within the Center of University of Vermont Center on Aging, working both within a clinical setting and a policy-based setting. And we will have a similar site placement this upcoming year. Another unique model is the cohort. Another unique element is the cohort model. Again, having a group of students being able to support each other through this unique experience, as well as be able to share their experience with the other students within the larger MSW cohort. And then also an interdisciplinary approach, students working with other professionals within the same agency, but also within the community, working with other professionals is something we want to really enhance within this internship model. Next slide.
Okay, so what's next?
Yeah, so this is what we've, with our amazing team, this is what we've been able to actualize for this, starting this upcoming fall for the fall semester of 2023. So we have a cohort of 3 students comprised of two first-year master's students and 1 advanced standing student. They're just in an accelerated track since they completed their BSW recently. So the 2 first-year students each have 2 placements, which will switch with each other part of the way through the year. And the advanced standing student will have the similar placement that I had previously had, where they're working within 2 different sites simultaneously. The students will receive a modest stipend. They'll also have an orientation, planned group orientation to help them connect with each other and connect to this unique model. Audrey, who's the program coordinator, will be holding monthly meetings with the students to be able to share their experiences together. And the cohort will also collaborate on a project that addresses a need within the field of aging. Next slide, thank you.
Go ahead.
Okay, we have a couple of questions that we're going to put out and probably hope to receive some emails and the like so that you can respond to this. I do want to just make a reference to Rhonda's earlier slides, the service and support pyramid and the care partner services, and all of our interns. And I know you're on the line today. Thank you for joining us today, new interns, soon to be new MSW students. And we will be working through that so that we will be integrated with dementia caregiving as we move along. So one of the things that's important is thinking about equitable access. That comes under that assurance part of public health. How do we provide and reach out to underrepresented populations? And they are in our community. They don't come into our clinics as often. And so we're really interested in your input on that. Lucas?
And our second question, as this is a fairly new model for us and one that we haven't been able to find other similarities out there, we're wondering if anyone has any feedback for this internship model that we've discussed here today. Thank you. And our next speaker is Janet Nunziata, Associate Director.
If that is okay, I'm sorry to interrupt, Lucas.
Yeah.
Just because we have about 12 minutes left, I would like to hear from the audience in the chat about your questions. If anybody has any programs that they are aware of in their states that they could maybe share about. I don't know if there's any feedback, any responses. If we can go just a slide back, Maya, that'd be possible. I really think this program is very interesting, and I would like to see what learnings there might be that others could share with you. any similar internship models that others are implementing. Otherwise, if anybody has answers, go ahead.
This is Delana Taylor, and I work for the Wichita and Affiliated Tribes Alzheimer's Dementia Program. And we're just starting, but what we did, which is we're just now getting our word out, but what we did was we developed a pad, a 6x6 pad that has the 10 signs of dementia on it. And it has, we gave it out to our IHS clinics and then presented it as a presentation that we're trying to coordinate our efforts with the clinics, so that if they come across a person who has dementia or has been diagnosed with Alzheimer's dementia or any one of the dementias, that they can talk about our program and then refer those cards to us. And they just tear them off and they check those boxes, and then we follow up with that patient and teach them about dementia. And I'm finding that so far, we did a presentation about a week ago, and we've already received 2 referrals from that clinic. And so that's one of the things I want to bring out to even the community health departments can utilize those. So if you have something that you could leave with the health departments, that they can utilize your services for counseling or teaching about dementia, teaching about problem solving on the stages of dementia. I think what I'm finding, and I live in a rural area in Oklahoma, the difficulty about this is that many people do not want to admit that they have dementia. And a lot of the problems that, or the issues that have been raised in the chat are the same and similar to what we're experiencing. We can have presentations, but the turnout is very slim. And it's frustrating because we know that they need it. And respite care is one of the things that I've run into a lot, regardless. We have 10 counties that we serve, and that's the number one thing that we run into is respite care. But that, going back to that referral slip, that is something that has been a useful tool. And it's not very big, you know, a caregiver can fill that out and call us in and talk to us over the phone. We could fill it out over the phone, or they can take a picture of it with their phone and send it to our email address, or they can mail it in. I mean, or they can leave it with the clinic and the clinic can call us and we'll go and pick it up. So there are various ways of getting that referral slip to us, but it's real simple, and it has as the person's name that they're referring, it has the referral, the person that's referring, and then it has those 10 signs where they check those boxes off, and then it has a 2-line comment, and then it has my email address and phone number at the very bottom. And that's been helpful.
Thank you, Deanna. And there's a couple of questions in the chat for you. Actually, there's somebody who would like to connect with you, so please feel free to share information with them there. And a comment from Rhonda, and kind of your case here brings me to a question that I wanted to ask Rhonda on behalf of the Vermont Bold team to see, and I'm curious how the Vermont Public Health Program plans to connect or integrate, align with what we've heard today, with the Bridges program for the workforce development initiatives, for example, or in the Caregiver Support Center. Would it be by referring caregivers, helping build a system to identify caregivers and connect them with the peer-to-peer volunteer program? I'm curious to see how the Vermont Public Health plans to leverage this great work that is being done.
Mm-hmm. Yeah, I would say yes to all of that that you mentioned, Elma. We want to track, I mentioned like that tracking piece, and how we build that is whether we can track in claims data. Can we track in another way where we're able to see that referrals are happening and people are caregivers are receiving supports. But that's a bit a ways away as we build that capacity. But one of the I think ways that we look for bridging over to our care partners here on this call in Vermont is through being partners on the Hub and Spoke ADRD work group, including their data in terms of, say they have pre and post or need help creating a pre and post for one of their programs. Our evaluator can help with that. We want to, and I guess lastly, is just through, and not only, but through communications, the communication tools that a health department has. Let's lend that to caregiver supports and caregiver programs. Have we done that to the best capacity yet? No, I think that's still work underway. But those are a few of the ways that we are looking at or already started.
Thank you, Rhonda. And we have just a few minutes left here before the end. And I wanted to hand it back to Janet Munziara, who was hoping to just introduce briefly the Center on Aging, even if it's just sharing the information. These slides will be shared with everybody. So you will be able to reach back to our speakers.
Alma, absolutely. Let me just mention, we've talked about the Vermont Bridges program. We're a partner in that program. I wanted to mention that go to the slide on the gerontology conference, please, that we have a unique model that includes professionals as well as family caregivers. And that's been working really well and helping with our dementia-friendly state efforts. And then finally, our Grand Friends program, which is an intergenerational program and has been very successful. The students who participate are excited to learn more about really working with older adults, what older adults are really about, the language of aging and so forth. So the social work faculty implemented this program last spring and it was very successful and we look forward to working with them. I'll leave it at that, Elma. Next, we had some questions, which if you have any questions about any of the programs we've just talked about or want to make a comment, that's where we're at now. Thank you.
Thank you, Janet. Thank you. And I'm sorry we didn't have time, but all of these slides will be shared and attendees will have a chance to reach out to any of our speakers today with any questions. Talking about workforce, I was curious earlier, Ron, would be a question for Rhonda and or Ed. I am wondering, you mentioned you have a plan to develop dementia certification for CHWs in the state. And I was wondering, what are the plans, Vermont's plans of how will the Department of Health leverage community health workers in supporting dementia caregivers? What is your plan for that?
It's still evolving. Just this week, as part of our Division of Health Promotion and Disease Prevention, we met with the lead for our community health worker program in Vermont. And one way is to support reimbursement through our state Medicaid office. I work closely with our state Medicaid agency on several fronts, and the reimbursement model and or incorporation of payment into the 1115 waiver once it's renewed, and I believe starting 2027, are several ways to support community health workers. So in terms of certification, the CHW in Vermont is working on certification pathways through our state education system. So our community colleges, Vermont community colleges. We may not want to wait that long to go through that route, but rather once that's established is to then add the dementia training component and integrate it as an offering. I think what we're honing in on is with the Alzheimer's Association of Vermont and the CHW lead is once she has basically an email network list that we can use to contact CHWs, we can ask them, what is the preferred dementia training? I think the Alzheimer's Association has several great options for us. We also did explore about 3 others. And so we will put it out to see what is most feasible and of interest, and then proceed from there.
Thank you. And I believe we are at time. Thank you so much for sharing about this work in Vermont. Lots of good work, workforce development, building an infrastructure to support caregivers throughout the state. Please, again, reach out to our speakers to learn from their work and continue this conversation offline. Connect with them in person, in a meeting. Reach out with your questions and share your ideas. Also, please reach out to us if you would like to share, if you would like us to share what you are doing with the rest of our BOLD community and public health community as we share best practices and really what's working, what can we replicate, adapt, and adopt in other places to support our caregivers. Thank you so much for being here today with us. And when Zoom closes, we please just take a couple of minutes to let us know how it went. What went well, if there's anything else we can do, offer in our programming to support you all in your work. Thank you to our amazing speakers today. Have a great day.